Welcome to our attendees. This is our November meeting of DIME's Virtual Journal Club, and I'm thrilled that we have Christine Manta, Dan Gottlieb, and Simona Carini, who will be leading a discussion around standards in digital medicine. I'm really excited about this topic. Christine led the development of an actual recent update of a really terrific blog post on the topic that I thought was really insightful. And I'm really looking forward to participating in the discussion today. Typically the questions that are asked really probe the content of whatever sort of journal piece we're looking at, and really help us think specifically about how to apply the topics to our new field. Some very brief housekeeping before I hand over to Christine. Everyone who is participating in the conversation is unmuted. Please feel free to either pop questions in the Q&A box or as I said, you're unmuted, so just speak up. It's a small group and intentionally so. We do really value discussion. If you do have a question for our panelists, please just briefly introduce yourself before you dive in for the first time so we can get to know everyone on the line. And just a quick note to everyone that we are recording. So Christine, with that, I'll hand over to you to introduce your co-panelists today and lead the discussion. Thank you, guys.
Thank you, Jen. So my name is Christine Manta. I'm a research lead at DIME, and I also lead research operations at Electrolabs. And I led the research for this blog post with help from Dan and Simona as well. So Dan, do you want to introduce yourself quickly, and then Simona can as well?
Sure. So my name is Dan Gottlieb. I run a small consulting firm focused on FHIR projects, helping people build clinical systems on top of FHIR and other related standards. I guess most relevant to this talk is that I formerly was the technical lead for the Smart on FHIR project, and currently work with HL7 on FHIR population health APIs. So I've been co-leading the development of those APIs for the last 2.5 years.
Awesome, thank you. Simona?
Hi everybody, so I'll have the video for during my introduction. So my name is Simona Carini. I am a data scientist at UCSF. My background is in nursing and data management in biotech and pharma industry. I've also been working in the Open mHealth project, which was co-founded by my manager at UCSF, Dr. Ida Sim, and since pretty much the beginning. And our focus right now is working within the IEEE, and you'll hear more about that, the IEEE framework to create a standard around mobile health data.
Fabulous. Thank you so much. I'm very glad to have both of you on the call today. All right, let's dive into first slide. So with the use of sensors and apps now, we can collect so much more health data than ever before. And integrating this data from digital tools into electronic health records is a really important step to making this data actually useful for clinicians, researchers, and patients. So how do we get there? Interoperability and implementing standards that actually work has been a constant challenge for healthcare. And now with this new influx of data from digital tools, we risk further burdening the system with untrustworthy and siloed data. So where do we start this conversation of standards for digital medicine? Because it's a huge topic that can be sometimes pretty overwhelming. So on the next slide, so at DIME, we wanted to start the conversation with a simple blog post that we published, Digital Medicine Standards 101. And we developed this graphic that shows the key stakeholders and relevant standards that our community should be familiar with. So this is very far from an exhaustive list. There's about 40 SDOs that actually work on health IT standards. But we felt that this graphic really distills the government agencies, SDOs, and different types of standards that are commonly used today. And I want to highlight the updates that we made on this second release. We added SMART and Smart on FHIR, which we'll dive in a little bit more into. And we also added the work group between Open mHealth and IEEE that we'll also dive in more detail today. So on the next slide, I just wanted to start with a couple definitions just to orient the conversation today. So today we're talking about standards, which is just simply an agreed upon method for doing something. They're established by consensus in the industry and then promoted by a regulatory body. So the government agency like the ONC, they don't set or like write their own standards, they just promote standards that have been established by consensus in the industry. So on the next slide, we'll dive into some of the different categories of health IT standards. So HIMSS recognizes standards in 4 different types. So content, which is often referred to as data models. Then we have terminology, which is structured vocabulary. I think these are the most common ones that people are familiar with. So LOINC, which is for health measurements, SNOMED, which is for clinical terms, and then ICD-10, which is billing data, which I think everyone is familiar with if you worked clinically. And then transport and exchange. So this is how information gets from one system to another. So for example, DICOM, which is specifically for images, and then FHIR, which we'll definitely talk more about. And the last category is privacy and security, which is really important because of HIPAA and GDPR, and that's where Smart on FHIR comes into play. So of all of those examples, which are the most important? Which are the most commonly used? The first one that I want to touch on is FHIR. So this is the most recent standard from HL7. It's constructed using data models called resources. And there are 2 key features of FHIR that I want to highlight. The first of which is that resources can reference one another to form a web of data. And this is really important for adding context when you're looking at a single resource. And this is a new feature of FHIR that is different than previous HL7 standards, which is pretty cool. And then the second piece that's important is that FHIR is built on protocols that are really familiar to developers from other industries. So resources can be represented in either JSON or XML, and they can be accessed over an API, which is a really important feature. And the next standard that I want to highlight is Smart on FHIR. So SMART is a project that runs out of Boston Children's and Harvard Medical School. And SMART as a project aims to create an ecosystem built on standards that allows developers to make apps that can function in any healthcare system regardless of the EHR vendor. So they built this app launch protocol that's constructed using OAuth 2 and OpenID Connect protocols that defines how third-party applications can access health data in a FHIR-supported EHR. So that's where the term Smart on FHIR comes from. FHIR defines how the data looks and how it's stored, and then Smart on FHIR defines who can access what. And SMART as an organization does a lot more than just this protocol, which we can dive into more in the Q&A that Dan can answer. So the next group that I want to highlight is this work group that is a collaboration between IEEE and Open mHealth. This group began in 2017, and they're working to develop standards for descriptions, exchange, and the use of data collected on sensors and mobile health applications. So if you have questions about how are we standardizing the data that's actually collected on the tools themselves, this is the work that this group is doing, and Simona can answer any questions about it. And they're really focused on sleep, physical activity, and mobility, and the metadata, which is really exciting. And I encourage everyone to check out the IEEE website for more info on it. And then lastly, I just want to highlight Open mHealth, a little bit more background on the group. So they've been around since 2011. And I think there's a lot of questions out there about how does Open mHealth, FHIR, and Smart on FHIR all work together? Which one should be used? And the answer there is that all 3 can be used together and probably should be used together to deliver the data that's patient generated from sensors and get it into a physician workflow within their EHR. And HL7 put together an implementation guide of how this should be accomplished, which we can definitely dive into more in the Q&A section. Cool. So all this sounds really great, right? We have these standards. They're for EHRs. They're for mobile tools, which is awesome. Can you go back one more? Thank you. So after I did all the research for this blog post, I was left with a couple questions. So are FHIR and Smart on FHIR really worth all the hype? Are they actually being implemented in a way that's meaningful? And it seems like, and I think this is probably up for discussion, there's a cautiously optimistic yes. Cerner and Epic are on board with adoption, which has allowed Apple to make their app that allows patients to access healthcare data right there on their phone. So that's a huge step forward, I think, which is exciting. And then there's two questions that I'll leave for the group as a starting point for our discussion here, which are existing health IT standards appropriate for the format and exchange of the data that we want to capture? Is FHIR going to be flexible enough to capture these new biomarkers and these new measurements? Is it appropriate for continuous data collection that we can get on these remote monitoring tools? And the second question is, do we need standards for how data is actually collected and stored and displayed on the tools themselves? So for example, if you have two activity trackers and they're collecting data totally different and displaying it totally different, which one is going to be trustworthy? Which one is the best to use? And this is where the Open mHealth and IEEE group are doing a lot of their work. So I'll leave these questions here and we can kick it off with any questions from the group.
And just a quick note to folks on the line, please feel free to either use the Q&A box. Alternatively, everyone's unmuted at our end. So if you want to take yourselves off mute, please feel free to pose a question directly.
No. What standard is Google using for its Nightingale project? That's a very good question. Dan or Simona, do you have?
I don't know.
That?
I don't know.
Yeah, I'm not sure.
I can only say that Google has been very aware of the work that Open mHealth and supportive of the work Open mHealth has been doing. Now, I'm not familiar enough with this mentioned project to be able to say that what they're doing.
Yeah, this is. Sorry. This is Dan. So I don't think we know yet, but I will point out that Google has earlier published a machine learning in healthcare paper where they converted data from multiple health systems into FHIR and then did their ML on top of that. So I mean, it's certainly an option. I don't know if that's a good thing or a bad thing for this new project.
I wonder if I can ask you guys a question. I've been digging into some work around how healthcare systems themselves can integrate generated health data. Is what's, and given sort of current state, Christine, you meant Epic and Cerner are on board with sort of diving in with these standards. How heavy is the burden going to be for healthcare systems who want to start integrating generated health data into their existing record keeping systems?
That's a great question. Simona, do you want to talk a little bit about how Open mHealth and IEEE can help bridge that gap?
Yeah, so the way I see it is that, so there's the overall topic of how do we move this patient-generated data into the EHR, and that's a topic that has different layers, because I would add as a question is like, do we want to do it? Because and that's actually, we can dive more because we did a project like that. So why do we want to do it and how do we want to do it? And so that to me kind of comes first in a sense, because there is this idea, and also what is the data that EHR has right now? It's data that is collected during occasional encounters between a person and their physician. So there is, one blood pressure, one heart rate, one body temperature, and one of a few things. So now imagine that person walks home with their own, device that collects blood pressure several times a day. So then all of a sudden you have the quantity of data. And so let's set aside, the security connected with the fact that now you have a device that feeds data into an EHR, which is protected. So that's one layer. There are a bunch of other layers. How do you identify the patient to make sure that the data that comes from this device is exactly the same patient in the EHR? But just from a volume perspective, and that's probably, I'm more sensitive to this because my Dr. Ida Sim is a physician, so I know it's like, why is that the physician needs to know about all these data the person is collecting? Does the physician need to know every single data point, like, let's say, 4 times a day? Does he need to know this, during the whole 3 months that the person, is at home and not seeing the physician? So the answer is probably not. And so this is actually where we've been working on, is like, so what is it that really the physician wants to know about this data, and how does he want, does the physician wants to know? The physician doesn't want to look at the device that it's separate from how they look at the other data. So there is this idea, and obviously Smart and FHIR is part of this, is like, whatever we decide that we need to surface for the physician, it needs to happen within their workflow. And their workflow is EHR based. And so this is sort of, and I will stop here. This is how we've been looking at this, sort of like, maybe it doesn't even matter that this data is recorded in the EHR, but it is available in a format that it's useful for the physician within the workflow that they are already using.
Mm-hmm.
Simona, I definitely have some follow-up questions on that, but I see that Jerry's popped a question into the chat. Jerry, do you want to give some voice to that question to the group?
Well, hopefully my laryngitis will pan out. Basically, as a clinician, I can address what was just discussed when I asked up here. What our problem has been integrating glucose meters, which is our big part of our diabetes care business, particularly with CGM. We have huge amounts of data, as you mentioned. And first, we don't need to know individual points. We need to know when people are trending in the wrong direction. So what we've talked about has been getting a dashboard set up where we can get alerts when a patient is falling off one way or the other, too many hypos or too many hyper glucose levels. But my first question was, our problem has been in the past integrating the CGM data from the various devices into our EMR without a huge cost. Most of the electronic record companies, particularly Epic, ask for an arm and a leg to create an individual API. I had hoped that these new standards would enable us to overcome these barriers and not have to pay huge amounts to bring data in. So what I understand as a real digital person other than a clinician is, will Smart on FHIR allow us to do this without huge cost? And that would allow us to do more things. And then also, as I said, the data we need is not every point of glucose data, but what the trends are, so we can get alerts when to bring people in to get them an intervention in a timely fashion.
Definitely.
So I can jump in here a little bit. So on the cost side, it's still a little bit in flux. So my understanding with Epic is that if you're building an app internally for your healthcare institution, you can build and deploy that at no cost, no additional cost other than developing the app. If you're selling an app commercially, right now I think you have to sell the app through Epic's App Orchard Gallery, or store, I guess is probably the non-Epic term. And then you do have to, there's revenue shares and fees, and so it's a little bit, it can get a little bit costly. That's up in the air a little bit because it looks like there's federal regulation that's going to be coming out probably in the next few months that would require, that would limit how much EHR vendors can charge for provider facing applications. and kind of put them on a model where they can only recover costs. They can't use it as a revenue source. So it's unclear exactly where that'll land. The integrations that they offer through Smart on FHIR right now are somewhat limited. So they support alerting on the patient face sheet. So when you open a new patient in the EHR, you can do calculations and get alerts through a standard called CDS hooks, which is related to Smart on FHIR. And then you can also launch an app within the EHR kind of frame, and that basically loads the app in a web page, but gives it access to EHR data through FHIR and does the authentication through Smart, so there's no like additional login step. So you can do you know, some integration with the EHRs. Your point about the cost is something that's kind of had a lot of discussion in the industry, but right now, if you want to sell the app commercially, you have to give a fair amount of that revenue to Epic.
Great. Thank you, Dan. I want to call on Lauren, who put a question in the Q&A. Lauren, would you mind sharing that with the group? If not, I can just read it. Oh, her audio is not working. Okay, great. Thank you. So Lauren asked, so she's a healthcare analyst. She's using Epic, attempting to break into project management in digital medicine. So she's wondering, are there any competitors to FHIR or Open mHealth who are developing their own standards? How are you identifying them? Is there a process of sharing each other's standards? Which is a really good question. From the research that, at least that I did, FHIR has the most momentum. So I don't know how much sense it would make for another SCO to try to develop something that would compete with it. Dan probably has more insights around that, but it seems like FHIR is really like what people have decided is going to be worthwhile to try to implement, and we've made great strides in doing so. And in terms of, yeah, go ahead. No, go ahead.
Sorry, I was just gonna say that I agree. I'm a little bit of a FHIR partisan, so it may or may not be fair to take my opinion. But if you kind of look at the industry, I think most of the health IT industry have decided that FHIR is kind of the most viable future standard, and pretty much everything is moving to FHIR. There's some work still done, you know, on legacy standards like the CDA standard, but as people build new things, everybody's really building on top of FHIR now.
For sure. And if you're interested in like how we're identifying the best ones and which ones, really the ONC, which is the main government organization that promotes them, they have a pretty solid list on their website, which I've linked to at the end of these slides. There's some resources slides. So that's going to be like your go-to hub, I think, for which standards are actively being promoted and which ones to pay attention to around implementation. Okay, there's another question from Luca. Do you want to ask that to the group?
Hey, hi everyone. I'm Luca Foschini. I run Evidation, run data science at Evidation. My question is pivoting a little bit to the clinical research side. So is there a good way to store high frequency multivariate time series data, such as the one on, you can get from accelerometer or continuous glucose meters as part of a regulatory submission, part of CDISC? Where is the right place to do that? Is there, I've seen some attempts to map FHIR resources to CDISC for EHR-like data. Could also that be the solution for bringing in time series data? And in the particular case, it seems like FHIR might have a limitation on maximum frequency you can express. But in general, what are the thoughts on multivariate time series on clinical research? Thank you.
It's an excellent question. For the purposes of this blog post, there was so much content to break down. And I think we really focused on the clinical care applications, because we could do a second blog post probably on the research applications. But Dan, do you want to speak to any work that FHIR has been doing around CDISC potentially, or even just storing the high frequency data?
Yeah, so I'm not familiar with a specific work on CDISC. I'm sure there is work going on within the FHIR community, but there's it's a fairly large community. There's a lot of projects going on at once. What I will say is, in terms of high frequency data, in general, people don't store that in FHIR natively. So, so what I'm seeing more of is people storing the data in some very compact, efficient format, and then when they want to transmit it, they're transmitting aggregated versions of FHIR. So the FHIR observation resource or data model has options to support different types of sample data. And so people might compress the data using, averages or, sampling at different rates, and then convert that into FHIR. Because FHIR is like a fairly verbose format. And so in terms of like high frequency data, it makes more sense as a transport a transport mechanism for the summarized data rather than the raw data.
Mm-hmm. Yeah,
Quick follow-up question there.
Yeah.
Oh, sorry.
Go ahead, Luca.
Okay, thank you. It was just really a quick technical follow-up. Would FHIR allow blobs, binary blobs, to be sent? So you can send the aggregate format, as you said, but then if someone really wants to, have the regional data, there's a binary blob that they can access.
Yeah, so FHIR does have a data model called binary, not surprisingly, where you can basically put a binary blob with some metadata and transmit it using the FHIR API. So you do have that option.
Thank you.
Simona, do you want to jump in? I know there's work that Open mHealth and I
are doing. So I have a couple of things also in terms of just standard and high frequency data, which is a very good topic. So thanks, Luca. So part of the way we look at it is also that this data usually is used to support the development of a biomarker, and so, for example, it's not. I don't think it's yet clear, and maybe I'm wrong, I haven't followed this, but it's clear what is it that is necessary on, on the clinical research side of how much of this data needs to be submitted. It seems more like it's the support to prove that whatever biomarker has been developed, has been validated properly. So I look at it more as support data. Within Open mHealth, I mean, we have made a decision for now to work on more like derived data. So sleep data and physical activity data, and we all know that underneath the raw data, it uses accelerometry and gyroscope. But we've made, we have to start someplace, and we made a decision to focus on the derived data, with the understanding that, of course, there is this thing about making sure that the underlying raw data, in some sense, it's made available. And so part of what we're doing for this this other topic is also work on a minimum metadata set. That's part of the IEEE, because metadata is very important. And so we're working on the metadata with an eye on more higher frequency data than sleep or physical activity. And and in terms of, I wanted to just say a couple of words about, this is going back to Lauren's question, is that, part of one of the great things that a person gets a sense by reading Christine's blog post is that how different standards work at different levels. And so, sometimes it's, so when you say, are there other standards, but let's look also at the different levels, because, different work focuses. And so in Christine's slide and then on the blog post, she has identified 4 different levels. And so the fact that there is, that people are working on the same topic, but they may be working on different levels. So there may be, one, for example, IEEE 11073 is very focused on transport, data transport. And Open mHealth is, and our IEEE work is more on semantic, on the data model. So they both work in the same space, but there are different levels. And so I think that's kind of something to remember. In terms of, our work, we're not aware, we're not aware of, some other group doing what we're doing. On the other hand, Open mHealth is open source. It's been always open source. So we know that other people are using it and they're expanding. Is that not always that information gets fed back to us?
Mm-hmm. Yeah, open standards, definitely very important. Jerry put another question in the chat. Jerry, do you want to ask that one to the group? It's a really great one about security.
Again, I mentioned I'm a recently retired clinician, but I'm still involved in digital diabetes care. We worry about, with all this information going back and forth, the security issues. Obviously, that's the big thing, like people hacking glucose devices, etc. What are the security aspects of FHIR that will make it protecting bi-directional information? Because the information will come into the practice may want to message or make interventional changes based on the collected data or the trends. How is the security set up with the smart FHIR apps? So Smart on FHIR kind of does 2 things. One is it uses web security. So it assumes that kind of the communication between an app running on your phone or in your web browser and the server, the FHIR server, happens with kind of the same encryption you use when you access your bank using either an app or or their website. So it's that transport layer security that's built into browsers and is used by most applications. Kind of on top of that, in terms of the authorization piece, so the login piece, Smart on FHIR uses a standard called OAuth and a standard called OpenID Connect. And basically, if you've ever used Google Docs and connected a third-party app to your Google Docs, it works the same way. It basically prompts you to, it redirects you to your authorization provider. So in the case of a patient, that would probably be the patient portal. And in the case of a provider, it would be probably your EHR. And then you log into that system, which then lets you connect the app using that authentication. So it kind of leverages these existing authentication providers to do the authorization on top of that. And of course, that puts the patient or the provider in control of what apps are connected to their data and what those apps can do. So when you do that connection, you're usually prompted and it says this app is requesting these specific rights to your data. So it might just be reading your vital signs, or it might be reading all your data. And it might be writing data, or it might not be writing data. And so you can kind of, most of it, it's usually an all or nothing selection but you have the option to not connect the app once you know what it wants to do. And then of course, down the road, if you want to disconnect the app, you can usually log into the patient portal or as a clinician into some EHR configuration screen and and delete that app connection. So that's really how the mechanism works. Is that kind of what you were wondering? Yeah, that was, again, because we've had recent problems with systems that provide insulin pumps being hacked and questions about data integrity in my world. That obviously is a concern. One other question I'll have you on is, will the wearable industry have to sign on to these standards? The Fitbits, the Garmins, et cetera, do they have to be involved at their end?
So I think that kind of gets to the question of, the different layers of standards. I think what I've seen some people doing is providing a Smart on FHIR application where people can connect from the app into the API. So it kind of bridges between the clinical system and the Fitbit API. So you can kind of have adapters along those lines. I guess another option would be for Fitbit to provide a FHIR interface into their data so you could connect third-party apps. But that's something that seems, possible, but you know, they would have to have an incentive to do that.
Well, not at Google.
But right now I have.
Yeah, with Google owning them, I suspect they'll be more interested.
Yeah, that's possible. And again, it comes down to, you know, with these high frequency data, maybe something like Open mHealth or even a custom format does make sense for all the data. And then you might want to convert a subset of that into FHIR, or for example, with genetic data, where you wouldn't necessarily put the person's entire genome into FHIR, but you might put specific markers as FHIR observations that can be pulled up in a clinical context. So I think it really just depends on, you know, what format makes sense for the data itself, and then what format makes sense for the part you want to expose to clinical systems.
Thanks.
Just a quick follow-up. We actually, we did a project that did exactly this. So using an implementation guide, going from mobile health data, step count, to a FHIR format, and then display the results within an EHR using Smart on FHIR. So part is, my addition is also that, again, you know, the EHR is a very structured, and there are a lot of legal and regulatory requirements. Companies developing mobile tools might not necessarily want to go there. And so, you know, having, and FHIR has a, you know, is a lot of complexity, and for good reason, because it describes a very complex environment, which is a, you know, a clinic in which there are various players and things happen, whereas the mobile health space, particularly in the personal devices, is much simpler. It's the person and their own device, and you know, usually the device measures a small number of variables. So there are ways of bridging, as Dan pointed out.
I wonder if I can ask a question that I think builds on a lot of the questions that have been asked today, which is it clear that the EHR is the place we actually really want to be storing all of this data? We know that's not what they were designed for, and I'm definitely understanding as you guys ask questions. Luke, I thought one of your questions was really good, and then Simona and Dan, in your remarks, EHR at best, even with a lot of work, can filter the data and provide it in a relevant clinical context, summarized, as I think all of our sort of experts on both sides of the panel have mentioned today. But I'm just curious about, when we think about putting all these standards together and having all of these sort of adapters, where should we be storing this data collectively if we want to mine it at a more sort of population level research?
Well, so this is Simona. So my answer, in fact, is like, we have different use cases, and probably the same answer is not good for the different use cases. And that's why at the beginning I said, so what's the use case? If the use case is the physician-patient relationship, well then, you know, as also Jerry pointed out, you know, the physician is interested in the term, in sense of glucose, you know, trends, is the person trending up, you know, what is, whereas, you know, if you're doing, and Luca brought up, you know, clinical research, well, that's a different story. There is a, you know, there is a intense, you know, studying of, you know, a very specific, very well defined phenomenon, and you need to store the data, because if there is a submission that goes with it, there are all the regulatory requirements. A lot of us collect data just for our wellness, just to see, you know, how we're doing. Do I want this data in an EHR? I mean, why? No, probably not. I mean, I just keep them on my phone. So again, I think we should probably always start, I mean, you know, a good place to start is, what's our use case? And then what is the solution that best addresses the use case? And in the case of, you know, the physicians, you know, the physicians and patients should be driving, you know, that process. And, you know, other cases. So I hope that as we get more familiar with how the data can travel is we go back and we focus on, what is the use case for, for this different, and then having solutions that address, the use case best. And again, the answer can be sometimes yes, sometimes no. For some patients, yes. For some patients, no. And maybe really the EHR, the only thing that has to have is the result of collecting all these data, or or a window on a storage of these data so that the physician can get a sense. Because the storage part, there's also, and I'll just briefly mention, there's also a lot of legal things. Is like, so if the patient, and you probably have heard this, so if the patient is trending up, what are the legal requirements for the physician to follow up, and when does this legal requirement kicks in? I mean, so it's complex, and that's because EHR has such an intense and important role that plays in the physician person relationship.
If I can,
yeah,
I think one of the issues that, again, physicians are afraid of is that we don't want to be responsible for patients' data on a live basis. We want it on a reflective basis. That is a problem for physicians. And as telemedicine gets more impactful, both from the user aspect as well as the financial aspect for physicians, we're going to have to overcome that barrier. What we do now is people sign on to their portals, that you're saying they know their data will not be reviewed as it happens. It's going to be something that's reviewed retrospectively. That kind of protects us, I think, legally. But it is a big fear for physicians that if someone calls in with a low sugar, we have to be online with them all the time. We can't do that, obviously.
Yeah, this is Dan. I think that those are really good points, and I certainly agree with Simone on this being very use case specific, how you would store your data and where you would store it. The one thing I just thought I'd add as a clarification in case it's helpful is that we often equate Smart on FHIR and FHIR with EHRs, but that's not always true. So a lot of institutions are using FHIR as kind of a common format for clinical data warehouses, as well as exposing those clinical data warehouses to apps, and those could be research apps. They might not even be patient-facing. So you can actually collect data from multiple EHRs and patient-reported outcomes and things like that, and aggregate it into a FHIR data store that could sit alongside the EHRs as well. So I think there's just throws another option into the mix, but I think there's a lot of permutations around where you can store the data depending on who's going to be accessing it, where you need to keep it from a legal perspective, the quantity of data, what sort of queries you want to enable, all those kinds of things.
Fantastic. Thanks, guys.
Cool.
Christine, did you see Lauren's question in the Q&A box?
Yeah. Oh, sorry. I didn't scroll all the way down in the box. Thank you. So she asked a really great question that I'll read as kind of a closer. So, do we see a future of implementing these standards as legal requirements in order for medical devices to be sold on the market? Which is a really great question. So in terms of being a medical device, so if like a Fitbit or Garmin decided to go through an FDA clearance to become a medical device, would they then have to adopt a FHIR API to be an API in FHIR to be able to access their data? Like, should that be a legal requirement to help with the interoperability and data access?
So it's a really interesting question. It's not something I've thought about specifically. The one part that I really like is I feel like patients should have access to their own data from devices. And I think putting it in a standard format is going to make that easier. So even just from that aspect, I think I think it'd be really valuable. I'd like to see some rules that require patients have access to their own data.
Yeah, I agree. It's more around data rights and governance of who owns this digital specimen that we're now collecting. I think that's a big question that still needs to be answered.
Just to add to that, also first a reminder that not all the tools, the digital tools that we use in the space, wellness space, are actually medical devices. Mm-hmm. So there is the process, as Christine mentioned. So if when the device maker has to go through to clear, for example, the Apple Watch for the AFib. Mm-hmm. But not all the digital tools maker want to do that. And then there is a recognition. I mean, this is a very evolving thing. What's true today, it's like the whole topic of software as a medical device, because then we realize that, so even in the Apple Watch itself, the Apple Watch does a whole bunch of stuff that is separate. So what you validate is actually the software that takes the data and provides information for that specific thing. So even the FDA and the regulatory agencies recognize that this is very, very in flux. Now again, some device makers, they may make a decision, and there are many out there that just don't want to go through that route of validating claiming that their tool is a medical device. That does not mean that they cannot be used, for example, by the person, or in the context of clinical research. Because sometimes in the research, it's easier to allow people, you want to collect a whole bunch of data, but it's easier for people to use their own device, to bring your own device. And so again, that's another use case, is like, how do we deal in a case in which we really want to collect data from a lot of people, but we can't just give a device to each one of them. And so we have this bring your own device kind of thing, which helps with it also helps a lot with people complying. So again, not everything needs to be a medical device. If you're collecting, the research collects just mobility data. But then there is all, so on the research side, what needs to happen is that you validate somehow, get validation like information, which I'm actually surprised this hasn't come up, but it's the word validation is very important, and I can Open mHealth is not in the validation space, but there are for example the Consumer Technology Association, they put up documents about validation protocol for consumer devices. So again, that's another situation in which it's an additional standard that operates in one specific area and covers that very important topicals like, is the data valid? Is this device measuring what it claims to be measured?
Absolutely. Those are some great points, Simona. Thank you.
Fantastic. I'm conscious of time, and we do promise to try and wrap up a few minutes early when we have these small group conversations. So first of all, Christine, Dan, and Simona, thank you so much for joining us today to lead this conversation. And equally importantly, thank you to all of our members who dialed in. I think that these small group conversations are incredibly valuable. We learn as much from you and your excellent questions as hopefully you do from our experts. So appreciate everyone's time today. Before we wrap, I just want to highlight very quickly a few upcoming events. Let me actually just pause here. Christine compiled a selection of resources that may be valuable. We will post this recording along with this slide deck, so you have access to these links and information. And then in the month of December, we actually have 2 webinars coming up. The first is in partnership with our colleagues at Exertia, and we'll be looking specifically at mHealth app guidelines and the recommendations that they put out this summer. And then Luca, thrilled that we have you on the line. Luca will be one of the experts co-presenting on a webinar on December 12th with our partners at Amazon Web Services. So, and we'll be providing a sort of overview and introduction to digital medicine, thinking in a very applied fashion. next month. So everyone, thank you for your time this afternoon. Christine, Dan, and Simona, many thanks again for sharing your expertise with us, and have a great day, everyone.
Bye.
Thank you for having
Thank
us.
you.
Just, if people want to email follow-up questions, I'd be, happy to answer. Thank you.
Thank you,
Bye,
Simona.
everybody.
Thank you, Dan.
Yeah, same. Thank you.
Thanks, everyone. Bye-bye.
Bye.